The webinars conducted by ICA have been on various topics, and regional anesthesia in children has been somewhat an area which is, I won't say neglected, but well, less often done. For the simple reason that for regional anesthesia, one of the main thing that keeps the anesthesiologist little guarded is that children are afraid of needles, and regional anesthesia or regional analgesia particularly, the children would be very scared of the needles. There are many ways of doing it. There are lots of advancements in the last few years, and in many centers in Europe and even in India, well-established cardiac centers have started uh, making use of the regional anesthesia as well as the regional analgesia for children a routine affair. And today we'll be discussing just that, and we have very eminent speakers for this. The session will be moderated by Dr. Maitree Pandey. Dr. Maitree Pandey doesn't need introduction. She's one of the very, very well-known pediatric anesthesiologists, and she is director professor, former head at Lady Hardinge Medical College. Lady Hardinge Medical College, as you all know, is one of the premier institutions of the country. And her areas of interest, apart from ultrasound, is pediatric anesthesia, obstetric anesthesia, and critical care. Lots of publications that she has. She is a fellow of the Indian College of Anesthesiologists, and she is an inspiring intensivist award as well. The national and international publications which she has in plenty. She will be speaking on the topic of regional anesthesia in neonates and infants. So, Dr. Maitree Pandey, the floor is with you. Kindly go ahead with your presentation.
Very warm good evening to respective Dr. Jayashree, Dr. Baljit, my colleagues and dear students. So first of all, I would be asking my colleague, Dr.
Maitree
Nishant.
ma'am?
Yes, yes. Am I audible?
Yes, you are, ma'am.
Yes, you
Okay.
are. Please go ahead.
So
Please go ahead.
I will ask Dr. Nishant to share the MCQs before my presentation. And my fellow, I will be speaking on the regional anesthesia, analgesia in neonates and infants. And Dr. Nishant, please share the MCQs.
Yes, ma'am. So these are the questions for you. It's just a primer, and we'll be discussing these questions later. So the first question is, dose of 0.5% bupivacaine heavy for subarachnoid block in a neonate is choice A, 0.2 milligram per kg, choice B, 0.3 milligram per kg, point C, 0.4 milligram per kg, and point D, 0.5 milligram per kg. Then the second question, which of the following is a recognized long-term complication of pediatric regional anesthesia? Chronic pain due to nerve injury, option B. Respiratory depression from residual anesthetic effects, option C. Permanent vascular damage, option D. Prolonged sedation. So just keep the answers in mind and we'll discuss them at the end of the webinar. Question number 3. Which of the following is the most common complication associated with pediatric regional anesthesia? Option A, nerve injury. Option B, infection at the injection site. Option C, local anesthetic systemic toxicity or LAST. And option D, hemodynamic instability. Okay, so another dose-related question. What is the maximum dose of plain levobupivacaine as local anesthetic? Option A, 1 milligram per kg. That is obviously in pediatrics. Option B, 2 milligram per kg. Option C, 3 milligram per kg. And option D, 4 milligram per kg. The last question, at birth, the dura mater ends at S3 or S4 vertebrae level. Option 2, S2 or S3 vertebrae level. Option 3, S1 or S2 vertebrae level. And option 4, L5 or S1 vertebral level? So these are the questions for today, just to stimulate you a bit. And over to Dr. Maitree.
Thank you, Dr. Nishant. So, as we all know that regional anesthesia analgesia is very effective in managing the pain, especially the whole perioperative period. Previously, it was thought that the neonates and infants do not feel pain, but this has been proven to be wrong. And effective pain management for neonates and infants is critical, as inadequate treatment can lead to both immediate complications and long-term cognitive and behavioral issues. And as we know that neonates, especially the preterm neonates, have heightened sensitivity to pain, which necessitates the use of specific regional anesthetic techniques. So with this background, I will be talking in next 15 minutes or so about the indications of regional anesthesia or analgesia in neonates and infants. I will be listing the considerations of pediatric anatomy, physiology, and pharmacology, how they are different from adults, and some regional enumerating only the regional anesthetic techniques used in children. And I will be listing the type of peripheral nerve blocks. So, safety is the major concern with regional blocks and anesthesia in children. And it has been seen that the pediatric regional anesthesia network, which has database which has examined nearly 1 lakh blocks in 20 odd hospitals, that their severe complications were not seen, and no permanent neurological deficits has been reported. And they have demonstrated that the safety level in pediatric regional anesthesia is comparable to that in adults. And the main concern is that as these children are not cooperative, or they don't understand what you want to do, so we have to perform this regional anesthesia under a general anesthesia or deep sedation. And it has been shown that these does not pose any increased risk. And the most common adverse events which were found were catheter related. That is, either the catheter was not functioning properly, there was a block failure, infection, and vascular puncture. So, the most tangible benefit of regional anesthesia in children is the profound quality and prolonged pain relief. And it also reduces the requirement of anesthetics, muscle relaxants, and when it is given along with general anesthesia, facilitating stable hemodynamics and faster recovery, leading to decreased length of stay in the hospital as well as in the NICU. And the other alternative methods of pain relief, which is usually given by opioids, and they are known to cause nausea, vomiting, respiratory depression, etc. And they can be avoided or they can be minimized. And for pain relief, other drugs like non-steroidal anti-inflammatory drugs can affect the mature renal system adversely in neonates and infants. And it has been shown that the most subtle benefit of regional anesthesia is observed in the positive influence on the stress response, cellular, metabolic, and immunological and hemostatic aspects in these children. So, as far as the indications of regional anesthesia are, that they can use for operative anesthesia, and especially in children who are at severe risk of complication during general anesthesia. Example is that inguinal hernia repair in former preterm infants younger than 60 weeks post-conceptional age, who are at severe risk of developing post-operative apnea. It can also be used in severe acute or chronic respiratory insufficiency, and children with severe metabolic of endocrine disorders, and also with neuromuscular disorders, myasthenia gravis, etc. Most commonly, regional anesthesia is used as for the perioperative analgesia. It can also be used for procedural pain like giving topical anesthesia or infiltration techniques. It has been also been used for management of non-surgical pain and chronic pain relief and in palliative care as well. The non-analgesic indications are sympathetic blockade to improve blood supplies. For example, if some drug has been inadvertently given into the artery and there is severe vasospasm, then it can be used for sympathetic blockade. So to know how to give a safe regional anesthesia in neonates and infants, it is very important to know about the anatomical differences from adults. So as we all know that, of course, a neonate is smaller in weight and height than adults. But where does the spinal cord end? The termination of the spinal cord is at the level of L3 or L4 in the neonates, and by 12 months it comes to L1. As good, it is as good as adult level. So the clinical implication is that subarachnoid block should be performed below L4. And the termination of the dural sac is that at the level of S3 or S4 in neonates, and as compared to S2 in infants and adults. So there is a higher risk of dural puncture in these patients. So frequent aspiration should be done while injecting and small aliquots of local anesthetic, and if possible, ultrasound guidance can be used. And as regard to the vertebral column, we know that for all age groups we have surface landmarks to know about the intervertebral levels. So that is known as the tougher line. That is the line joining the anterior superior iliac spine, highest point of iliac crest, and it is at the level of L5S1 in neonate, and it is neonate and infants, and in adults it is at the level of L4 and L5. And the curvature of the spine is single in the neonate with a higher degree of flexibility, and cervical curvature appears at the age of 3 to 6 months, and the lumbar curvature appears at 8 to 9 months. So in adolescents and adults, a steeper needle insertion is required as opposed to a straight, horizontal in the neonates. And at the same time, in infants and neonates, there is an increased cephalate spread of local anesthetic due to lack of lumbar lordosis compared with adolescents and adults. Now, the vertebrae bones are cartilaginous in neonates. There is some ossification at 1 year. So, we should avoid sharp needles as it may traverse into the bone, damaging the ossification nuclei and increasing the risk of intraosseous local anesthetic injection. Hence, a short bevel blunt tip needles should be used to decrease this risk. The good part of this is that there is better visualization of the anatomy within the spinal column with the use of ultrasound. And the sacral vertebrae, there is incomplete fusion in neonates. The fusion begins by 8 years of age. So we can make use of this for giving caudal anesthesia. And we must remember that fusion begins at 6 to 8, after 8 years of age. It may be difficult to administer caudal anesthesia. So regarding the epidural space, there is increased fluidity of epidural fat, and the fascia and sheets are loosely attached in neonate and children up to 6 to 8 years of age. So it is easier to thread the epidural catheters. And previously, when we didn't used to have the epidural catheters, and we used to be afraid in giving the neonatal thoracic and lumbar epidurals. So in prolonged surgery, abdominal and thoracic surgeries, we could thread epidural catheters from caudal space. However, the flip side of this is that there is leakage of local anesthetic around the nerve roots, and there is a relatively large volume of local anesthetic is required to achieve a high quality epidural block. Regarding the ligaments, they are less dense in neonate and infants. And so when we are giving epidural, the loss of resistance is subtle. Loss of resistance you feel is subtle, and you have to be very careful when you're giving epidural in neonates and infants as compared to adults. The meninges, the pyometer are very, very highly vascular. So the clinical implication is the systemic local anesthetic absorption is faster, and CSF volume is more in neonates, 10 ml per kg. In infants, it's around 3 to 4 ml per kg. And so a relatively larger dose of a local anesthetic is required when performing spinal anesthesia compared with adults. At the same time, they have a shorter duration of action compared with adults. The CSF volume is also around 50% in neonates and infants. So, similarly, a larger dose of LA is required when performing subarachnoid block. In coming to the autonomic nervous system, the sympathetic nervous system is immature with parasympathetic dominance in both neonates and infants. So, the peripheral vasodilatation and hypotension are less common when performing central neuroaxial blocks compared with adults. Coming to the peripheral nervous system, the nerves myelination is immature, so it is completed by the age of 12 years of age, and this leads to a rapid penetration of the local anesthetic in the nerves, producing a faster onset block. And a low concentration of local anesthetic can achieve a high quality dense block. The endoneurium is loose in neonates and infants, and so there is resulting in greater spread of local anesthetic, producing a faster and high quality block. At the same time, local anesthetic is absorbed quickly, producing a shorter duration of block, as well as it can lead to systemic toxicity if larger dose is given. The vascular surrounding the nerves are also rich in neonates and infants, and this also results in shorter duration of the block. Now, coming to some of the pharmacokinetic differences between children and adults, and they have a higher cardiac output and lower tissue binding, resulting in higher rate of systemic absorption. So there is increased risk of local anesthetic systemic toxicity. At the same time, they have a higher volume of distribution, leading to low plasma concentration and low plasma concentration of alpha-1 acid glycoprotein. So this results in increased unbound fraction of local anesthetic in the plasma, and this also leads to increased risk of LAST. As we all know that the hepatic enzymes are immature in neonates, and these enzymes which metabolize the local anesthetics, especially the amide local anesthetics. So it may be the half-life of these may be 3 to 8 times longer than in adults, and thus having increased risk of systemic toxicity. And at the same time, the clearance of bolus injection is faster, as the is also faster in children, and the clearance of amide local anesthetic is decreased after a bolus injection, and elimination half-life is prolonged up to 2 years of age. Now, when we are giving continuous infusion, we have to be very careful, because lignocaine continuous infusion results in substantial decrease in intrinsic clearance, and it is not advisable to unsuitable for continuous infusion in neonates. And if it is the other local anesthetics which are given in infants, they should not be given beyond 48 hours. Ropivacaine clearance remains unchanged. Now, as we all know that spinal anesthesia is an alternative to general anesthesia in neonates, infants, and adult children. And the duration of the block is age dependent and is considerably shorter than in adults. The typical duration is around 1 hour. And to prolong the duration, we can add preservative-free adjuvant drugs. And in children, the advantage is that the spinal anesthesia preserves the blood pressure better than general anesthesia in inguinal hernia repair. And certain studies have shown, and it has also been shown that this is a good technique in premature infants for this hernia repair. And it can also be useful in pediatric outpatients for certain surgeries. It has been of benefit in sick neonates and preterm babies as a sole anesthetic, and it can be administered when the patient is awake. It decreases the risk of post-operative apnea, and the cardiorespiratory disturbances are also minimum. So there are certain controversies in pediatric renal anesthesia, and most of us are worried that when we are giving anesthesia to these children or analgesia, they have to be anesthetized. and there is a potential risk of child being unable to bond regarding any nerve injury. But it has been found to be safe when we are giving anesthesia in this regional anesthesia and in under general anesthesia or deep sedation. Now, the another controversy is that whether to, when we are instituting epidural anesthesia, whether to see the loss of resistance technique by air or saline. Both has its own pros and cons, but saline is used more commonly for identification of epidural space, but it can also have some drawbacks, like it can be mistaken for cerebrospinal fluid. Use of air in children, neonates may result in air embolism, root compression, pneumocephalus, and incomplete analgesia. Regarding the test dose, which is normally used during epidural anesthesia, we want to know whether the catheter or the needle is properly placed. So we give a test dose to know whether inadvertent intravascular or intrathecal injection of the drug is not done. So as we all know, the aspirator's test to elicit blood or CSF is not very sensitive, and test dose is usually given with epinephrine 0.5 mics per kg, and with around some people also use lignocaine 0.1 ml per kg with 1 is to 2 lakhs epinephrine. And in neonates, it has been seen that this epinephrine dose may lead to cord ischemia, so the more dilute solution can be used, which will be covered in later discussions. And as far as it has been seen that the IV injection of local anesthetic while practicing local anesthesia can be detected by ECG changes, and it has been seen that there are 25% changes in T wave amplitude or ST segment size, and there is an increased heart rate of more than 10 beats per minute or increase in systolic blood pressure of more than 5 millimeter of mercury. But these changes in blood pressure and heart rate can be masked during general anesthesia. So we have to be very careful. So we can give a fractional test dose or a slow injection of whole local anesthetic under aliquots, under hemodynamic and ECG monitoring. The other controversy may be that the patient, the child may not be able to tell about if the pain, if there is a compartment syndrome, which is a pathological condition characterized by the increased pressure in the closed muscle compartment. This is usually seen in the forearm or in the peripheries, and the patient usually who have trauma. So if it is untreated, it can lead to loss of muscle tissue, hyperkalemia, metabolic acidosis, and so on and so forth. So and a very dense block of regional block can mask the pain due to compartment syndrome, so it should be avoided. The least concentration of local anesthetic that provides adequate regional block should be chosen. And if the there is evidence that the child is in pain, then we should not step up the analgesic or the local anesthetic boluses without evaluating for the compartment pressure. So, but there are in literature, the evidence is scarce to suggest that regional anesthesia increases the risk of compartment syndrome. There are various regional anesthesia techniques. I will quickly run through those. And as you all know that previously only two regional anesthesia techniques were practiced, that is spinal anesthesia, neonates and infants, and older children, and caudal block. Nowadays, for abdominal and thoracic surgeries, we are using caudal epidural, lumbar and thoracic epidural, and it can be caudal epidural can be given by a traditional landmark technique or peripheral nerve stimulator guided technique or ultrasound guided technique. However, for lumbar and thoracic epidural, expertise and training are essential. The equipments must be customized, and preferred needle is 20 gauge or 19 gauge with 5 centimeter tube needle, or 22 or 21 gauge catheter. The complications which can be very severe, so we have to be very careful when we are giving spinal. There may be spinal cord injury, paraplegia, total spinal, and local anesthetic systemic toxicity. The peripheral nerve conduction blocks have been there for the last 2 to 3 decades. And as we all know, for upper extremity, we are using brachial plexus blocks now. Infraclavicular plexal blocks are known to be more safer, and these are being used in the neonates also. And lower extremity blocks like femoral block, peng block, psoas compartment block, sciatic block, and in its various forms are being used. Almost all the blocks which were given in adults can be used in neonates and infants. And recently there is an upsurge of facial plane blocks, and it has also been used in neonates and infants. With the advent of ultrasound, we feel more safe when we are instituting these blocks, and there are certain advantages in neonates and children because the visualization of nerves and adjacent anatomy is very helpful in these patients. The USG pictures of soft tissue structures are mostly like those of adults, but we must remember that neonatal bone is cartilaginous, and the relative lack of ossification produces different ultrasound images of the bones. For example, while performing a sciatic block, the femoral head lacks the characteristic echogenicity of the bone and may be difficult to visualize. So, and but the better part is that the lack of bone density creates some acoustic windows, and we can providing unique opportunity to access the neuraxial whole spinal cord. And during real time imaging of the can be done during imaging of the neuraxis can be of these blocks can be done when we are using paravertebral blocks and other blocks close to the vertebral column. Now with the advent, we have to know that how to prolong the blocks. Of course, we can use adjuvants, but in certain conditions, we need block for longer periods. So continuous catheter techniques are used to prolong the duration of analgesia. They reduce the post-operative opioid requirement and their associated adverse effects. It leads to early ambulation and shorter hospital stay. And but it is not without any complication or any problems, because it has been seen that even though it may be left up to 7 days, after 4 days it may lead to increased chances of infection, catheter related infection. And mostly in these when we are using peripheral nerve catheters, the adverse effects may be related to the catheter equipment failure or migration of the catheter, blockage of the catheter, leakage, and sometimes there may be skin reaction resulting from dressings. And nerve injury, if there is very of transient duration. And so after giving an overview of the pediatric, how it is different in neonates and infants, I would be talking about some clinical pearls that how to use regional anesthesia in neonates and infants safely. So first and foremost, that knowledge of pediatric anatomy, physiology, and pharmacology is mandatory. We must first discuss the plan with the surgeon and the child's guardian. And it is always better to perform the block in anesthetized state, except neuraxial blockade in neonates. Monitoring of the vital parameters is mandatory. ECG and baseline systolic blood pressure and heart rate should be noted. If ultrasound is available, we should use it to guide needle and visualize the drug spread. We should avoid the needles near the blood vessels, nerves, pleura, and vital organs. And facial plane blocks are preferred over other nerve blocks. So training and education is essential for better safety for performing these blocks in these small children. Before going for the blocks, it is very important to know what you have, what equipment you have, whether you want to give single shot technique with short or long acting local anesthetic, or you want to give local anesthetic with adjuvants, or you want to have a catheter technique with a repeat or continual injection of local anesthetic. Remember, with catheter technique, monitoring is very important in the post-operative period. You cannot just leave the catheter with the child and ask them to go in the ward just like any other children. And selection should be of equipment should be as per the recommendations. And we should, at the same time, we should have the proper assessment of pain relief. We must follow up the block efficacy and adverse events. And last but not the least, we should be very thorough with documentations. Of course, we must be familiar with the contraindication, limitations, and the complications of whichever blocks we are using. So, in the end, I would like to conclude by saying that regional anesthesia in pediatrics, and especially neonates and infants, is a valuable and safe tool to treat perioperative pain and also for operative anesthesia. It provides excellent pain relief and allows use of multimodal analgesic techniques and decrease the use of opioids. Safe ultrasound guidance has shifted our practice from neuraxial blocks to regional nerve blocks and facial plane blocks. Neuraxial blocks continue to have a definite place in major cavity invading surgeries. Novel region anesthesia techniques like anterolateral or posterolateral trunk blocks show more promise. Adjuvant medications and ambulatory catheters increase the duration of regional anesthesia and facilitate cost effectiveness and early hospital discharge. And we should have a better understanding of the local anesthetic systemic toxicity so that we can prevent these complications and prevent, and if it occurs, we can treat them. Thank you so much. So,
Thank you, Dr. Maitree. I would request you to carry on with the moderation of the remaining three talks. You have
okay.
very nicely highlighted the anatomical, physiological, pharmacotherapeutic, and pharmacodynamics differences between regional anesthesia for adults as well as the children. And I think it would be lot of new information for particularly the youngsters to practice regional anesthesia, and it'll be quite a bit of motivation the way you have described.
Actually, the main take-home message is that it is quite safe if you expertise this thing and you know about all the complications.
Very
Uh,
true. Very true.
So
You
I would
have
like,
highlighted this. Yeah, please carry on with it.
thank you, Dr. Baljit, thank you. And I would like to introduce Dr. Nishant Kumar. He is a professor in our department at Lady Hardinge Medical College, Department of Anesthesia. And he will be speaking on the advanced ultrasound-guided regional anesthetic techniques. Over to you, Dr. Nishant.
Good evening, ma'am.
I will stop the share, okay?
I'll just, yeah. Okay, I hope you can see my screen.
Yes, we can.
Okay. So I'll be talking about advanced ultrasound guided oblique. I'll be talking of both, basically advanced regional anesthesia techniques, whether landmark based, PNS based, or ultrasound guided techniques in children. So to start with, I've got absolutely no disclosures. However, I am guilty as charged for taking some of the images from Google, and these are where I have not attributed them to any of the publications. So one of her colleagues has said, show me a nerve and I'll block it. So that is very true with ultrasound. And I say, this is my own saying, and I feel very strongly about it. If a nerve can be blocked under anesthesia, it should be.
Dr. Nishant, can I interrupt? I cannot see your slides.
Can you see it now, ma'am?
No.
I can see it very well, Dr. Maitree.
Others can they see? Others can see?
Yes.
Okay, then I will just listen to you. Okay,
Yeah.
go on. Sorry
Okay.
to interrupt.
Sorry. So one of her colleagues has said, show me a nerve and I'll block it. And to that, I add, if a nerve can be blocked, it should be, especially when providing anesthesia or analgesia. So yeah. So I'll be talking about neuraxial versus general anesthesia, central neuraxial block in children, which is much more than caudal. The use of ultrasound in children, what unique considerations are there? And obviously the advanced blocks, the new block for the kid, as I call it. So neuraxial versus general anesthesia. Now there has been a lot of talk that when we provide general anesthesia to neonates, premature children, infants, and even children, GA has been associated with long-term neurobehavioral effects. Although this has not been conclusively proven, but then in large studies in progress, and it has been shown, definitely shown, that when we administer intravenous and inhalational agents to children less than 3 years for more than 3 hours or for repeat procedures, it does have a it does cause neuroapoptosis, which is dose and time dependent. So yes, GA, which we have considered as safe for children, is in fact so. When we talk of regional anesthesia, it can be used alone or in combination with general anesthesia. Obviously, ma'am has already listed the benefits of regional anesthesia. When used with GA, it decreases the volatile anesthetic, sedative, and opioid, and therefore decreasing the dose and time-dependent administration of general anesthesia drugs. And it can also be used as a sole anesthetic, especially so in infants, neonates, and even older children. Not in the middle range because they have, as Dr. Baljit introduced the topic, they are afraid of needles. But infants, neonates, and older children with counseling in the older children, you can use it as a sole technique. So that brings us to the different types of the regional anesthesia techniques. Now, the classical and the time-tested central neurological block, which has been used since ages, whether alone or with sedation or with general anesthesia, has been the caudal block in children. But believe me, central neurological block in children is much more than caudal itself. So let's talk about subarachnoid block. Now here you can see a neonate being anesthetized with a subarachnoid block, sucking his thumb, fully awake, and the surgery being performed. So that's the beauty of a subarachnoid block in a neonate. It is very safe in neonates and infants. And what we worry about in a subarachnoid block is the hypertension. That's the first thing that comes to mind when we talk of spinal block in adults. But luckily, in children, because of the immature sympathetic system, there are no variations in blood pressure. But yes, there are limitations because of the fast uptake and rapid metabolism. The procedures that can be performed in the subarachnoid block can be limited to only less than 60 minutes. However, this can be extended by adjuvants in the older children. Adjuvants are generally not advised for infants and neonates in the subarachnoid block. In addition, just like the CAC technique in the adults, the subarachnoid block can be combined with either caudal catheters or epidural catheters. I think Dr. Anshu will elucidate more in the next talk about prolonging the blocks, but then combined techniques in these group of patients is also possible. So it's a vast majority of surgeries that can be performed under subarachnoid block, although of limited duration if used alone. But yes, with the help of catheters, we can prolong the block and we can go for lower abdominal surgery, extremity orthopedic surgery, omphalocele repair even, exploratory laparotomy. Even myelomeningocele repair has been reported to be performed under subarachnoid block. In older children, like adults, they may have backache, transient neurological symptoms, and PDPH as side effects, but the incidence is not more than that of adults. So it is the same risk as that for adults. The risk is definitely not increased. This is just a table. I've taken this from Miller, so you can refer to Miller. These are the usual doses of local anesthetic for spinal anesthesia. The adjuvants which can be used are clonidine, fentanyl, and morphine. Remember, apart from morphine, none of these drugs are FDA approved, but yes, they have been used and are being used as a part of good clinical practice. Coming to the epidural catheters. Now, when we talk of epidural space in children, we think only of caudal, be it a single shot, be it catheters. It has been thought that administering lumbar or thoracic epidural is difficult, fraught with challenges. Then it can cause complications, can cause damage to the spinal cord. However, I need not elucidate on the benefits of the segmental block that the lumbar or a thoracic epidural provides vis-a-vis the caudal, wherein you have to give a larger drug volume, increasing a larger dose, thus increasing the complications. And even if the catheter is inserted in the caudal space, we wouldn't know where it lies because we'll be inserting it blindly. It might be coming out of the vertebral foramen, or it might be going in too far in, getting coiled or knotted. It has problems of its own. Now, however, when we give a large volume in caudal or in the epidural space, or we use ropivacaine or bupivacaine or levobupivacaine, even lumbar or thoracic, and especially with infusions, the main problem is that of LAST or local anesthetic systemic toxicity because of the immaturity of the hepatic microsomal enzyme system that is immature. So the drug which has been recommended for continuous infusions in children is actually 2-chloroprocaine because it is metabolized by plasma cholinesterase, and the usual dose is 7.5 to 15 microgram per kg of infusion. Can be given as a single bolus and then continued as an infusion for up to 48 hours, as was said earlier. Remember, you have to limit the dose of infusions because this can actually result in lust. Now, as ma'am had said, you can see here, we never see this beautiful picture of the thoracic cord, central neuraxis at the level of the thorax in adults. But this is an ultrasound image where all the structures of the spine are visible in a cut section, and we can easily identify all the spaces, and which can help in performance of the block, and we can actually do it guided and to a certain extent under vision as well. So this is again a table from Miller, which gives you the epidural drugs and doses. The postgraduates can refer to Miller. Adjuvants in basically infants and less than 6 months of, the neonates and less than 6 months old. Epidural adjuvants are avoided, but you can use fentanyl, fentanyl or clonidine. Do not mix the adjuvants, use only one adjuvant, and you can have fentanyl, morphine, hydromorphone, or clonidine, which can be used in continuous infusions as well. Now, coming to the classic old caudal block. Traditionally, it has been performed using the landmark technique where we make an isosceles triangle, keeping our fingers in the posterior superior leg spine and then feeling for the sacral cornu. Things have been made easy with an ultrasound probe. So as you can see, this is the transverse, this thing where we can see the sacral cornua, and we go out of plane using a blunt 5 centimeter needle, blunt tipped beveled needle, and this is the in-plane approach where we place the probe longitudinally. We can see the vertebral levels. We can see the needle entry and the deposition, nice deposition of LA. But remember, the needle insertion into the epidural space, into the caudal space, should not be more than 3 mm per kg beyond once you pierce the sacrococcygeal membrane. So basically, if a child weighs 5 kgs, you do not go beyond 1.5 centimeters into the space. Don't put in the whole needle inside the caudal space. So that is the caveat. And the problems, troubleshooting, if you see a subcutaneous bulge, that obviously tells you that needle is in subcutaneous tissue. You withdraw, reinsert, and seek the giveaway feeling, or you do it under vision. That is the best thing that you can do. If you aspirate blood or CSF, that means you have either entered the vessel or the dural sac. You have to remove the needle. And if you're not sure, inject in liquids. If there's a sudden arrhythmia or a change in heart rate, so it is either an undetected intravascular injection or an intraosseous injection. Remember, intraosseous is same as IV in children, and because of the loss of or less dense density of the bones, it is very easy to pierce the bones and feel a pop sensation of the membrane as well. So immediately you stop the injection, call for help, and continue with supportive efforts and activate the last protocol. So if you're using PNS, if you see the motor response with a very low current, that means you've entered the subarachnoid space and your needle tip is in the CSF. Now, what are certain unique considerations in children? We use ultrasound day in and day out for regional anesthesia in adults, but there are certain considerations, there are certain things that you have to be careful about in children. Now, as we have seen that there's a better visibility of structures, definitely yes, because the tissues are soft, thin, and that's why there is a beautiful image that is, if you want to learn sonoanatomy, I think a child is the best dummy or mannequin that you can have. But at the same time, slight test of the pressures will distort the tissues, and that will make your life difficult giving in the block or depositing the LA and identifying the structures as well. So you have to be very soft, very gentle, as you have to be with other things in the children. Since most of the structures are superficial, a high frequency probe is required, and usually The footprint of the probe should be small because, as you know, the space you require is very less. And since the structures are superficial, there's a higher chances of neural injury as well. The fascia and sheets are thin, so it's very easy to miss them and cause an intramuscular injection, which usually manifests as no effect. We feel okay, fine. I was in the right place. I saw the muscle bulge. I saw the sheet separate the separation very good. But in fact, it could have been an intramuscular injection that can be easily mistaken for, and ultimately the child is crying in pain, or you see a hemodynamic effect, which you thought would should have been blunted since you had used a plain block. And because of the absorption and the changes in physiology, as ma'am has already elucidated, there's a fast onset of blocks and the plasma levels are achieved quickly, leading to an increased risk of toxicity. Therefore, one should use a lower concentration of LA. But then, since these are volume dependent blocks, all the facial plane blocks are volume dependent, we have to decrease the concentration so that the dose can also be limited. Remember to use shorter and finer needles. Most of the blocks can be performed using the hockey stick probe. It has a shorter footprint, it's easier to hold, you can see around it, and you can insert the needles uh, also very easily. Instead of dissecting with the small doses of local anesthetic, it is always better to hydrodissect because you don't know where you might be. And only once you are sure that you're in the right plane, only then inject the local anesthetic. You can always use the concomitant PNS to be doubly sure. And please perform these blocks in adults first before you do it in children. So expertise is required in children before you do it in uh, children. It's required in adults before you do it in children. Now coming to the new blocks and the advanced blocks. So this is the entire list of blocks that we have been performing in adults. And remember, none of these blocks are contraindicated in children. Some are easy, some are difficult. We have been giving them using landmark technique, using the PNS. Then with the feasibility of ultrasound, it might be easy, slightly difficult to perform, or really difficult to perform. And whether a catheter can be placed in these blocks for these blocks or continuous blocks or not is also there. Again, this table is from Miller, so PGs can refer to that. Now, there are certain surgeries which are unique to the pediatric patients. So when we come to the head and neck surgeries, please make sure that you administer these blocks because these are easy to administer and that will spare you a lot of opioids and muscle relaxants. So coming to the head and neck blocks, supraorbital and supratrochlear nerves, which are superficial nerves, and these can be blocked very easily using landmark techniques and simple infiltration. And this is very helpful for frontal surgeries or vital surgeries and forehead surgeries. The maxillary nerve block, again, very easily performed using the ultrasound. Thankfully, to the less dense maxilla, not fully ossified yet in younger children. It can be used for nasal surgeries and for surgeries on the face. Infraorbital nerve, cleft lip. We usually load them with opioids, but infraorbital nerve, given easily with blind or using ultrasound, uh, saves a lot of opioid and relaxants for cleft lip surgeries. Greater palatine nerve for palate, mandibular nerve for your TM joint ankylosis, which many children, and mandibular distraction in neonates and younger children. Superficial cervical plexus blocks for tympanoplasties, meningioplasties, and neck surgeries can be given bilateral also. It can be given as an infiltration or using the ultrasound. Now, for lower extremities, quite a few pediatric orthopedic patients come with hip dysplasias. So, a PENG block, fascia iliaca compartment block for the hip surgeries, and for surgeries at knee or below that, adductor canal block instead of the popliteal block using ultrasound provides excellent analgesia. Many of these young patients come for circumcision. So, a penile nerve block using either ultrasound or a landmark guided technique, and the penile nerve works wonderfully, both penile and penile nerve blocks, with the penile nerve having a slight advantage over penile block for erythroplasties. I mean, we have been using pudendal nerve block for exclusively a lot for our erythroplasties, and the patients are usually pain-free for up to 12 to 24 hours later, and they help. That provides the helps the surgeon also in post-operative dressings as well. So all these blocks can be given using ultrasound. Now, as you can see, the probe is kept just below the eye, and you see a disruption of the bone table, the needle coming in, and that is where you deposit the drug. Mandibular nerve, it might be a bit difficult to see the nerve, localize the nerves per se, so the drug has to be deposited into the pterygopalatine fossa. The effect might be a bit varying with when you use ultrasound, although the ultrasound technique has been employed, but it is a bit difficult. So as you can see, a PNS needle is being used. I'll show you a video next minute. And for the maxillary nerve block, very easy to give. We keep it below the zygomatic process. Insert the needle suprazygomatic from the suprazygomatic approach. You see the temporal muscle, the maxillary bone here, the sphenoid bone, and exactly at this curve of the sphenoid bone, you deposit the LA to block the maxillary nerve. So this is how you can perform the maxillary block. Now, as you can see, if you see the landmarks here, this is the zygomatic arch, the sigmoid fossa. So you insert the needle directly into the perpendicularly into the sigmoid fossa and hit the pterygoid bone. Move the needle slightly posteriorly and inferiorly and switch on your PNS. Now, as it's going in, you can see nice contraction of the masseter causing the jaw to move in and out. So this is so easy, and you can see the contractions even at 0.4, drug is being injected. And I usually prefer to perform a rash test, and 0.2 ml per kg of drug is usually administered 0.25%. It can be given bilateral, and most of my TM joints in children are being done without relaxant and without opioids. So no opioids, no relaxants, bilateral block, and patients do not require any analgesia for up to 20 hours post-operatively. And obviously, I add dexamethasone as an adjuvant. So now you see as the drug goes in, the contractions have dissipated. So for the lower limb, we have the fascia iliaca and the peng block as you do it in adults. For the lower limb, pudendal nerve block, again, it's better given using either the landmark, better still with the PNS. Ultrasound, you see the pudendal artery, and then you put in the needle out of the plane and you deposit the drug around the pudendal artery. So you don't actually visualize the nerve in that, but yes, with the help of PNS, you get nice contraction of the anal sphincter, and that is how you can administer drug. Now, coming to the plain blocks in children. So, as ma'am had said in her previous lecture, all the blocks that can be administered for adults can be administered for children as well. So, we have the PEG block and serratus anterior block for the anterior chest, and thoracotomies, breast surgeries, rib fractures. Even this has been used for your cardiac surgeries and sternotomies. Also, for PDAs, rectus sheath block for abdominal surgeries, transversus abdominis block again for lower abdominal surgeries, ilioinguinal iliophysic block easily performed using ultrasound, PNS, or blind for inguinal hernia, orchidopexy, and hydrocele repair. QLB for abdominal surgeries, however, below the umbilicus, erector spinae block, a wonderful block can be performed from the thoracic to the lumbar levels. This has virtually surpassed the use of paravertebral block now. But if you're intending to put in a catheter, if you want a long-term pain relief, then paravertebral block would still be preferable over erector spinae block. But then please remember when you're performing erector spinae block that the needle can actually go in and pierce the transverse process, and you can have intraosseous injection rather than just the LA in the plane. Right. So again, these are the complications and considerations that have been very well covered by Dr. Maitree in her previous lecture, and these will be further covered by Dr. Nitin in detail in the last lecture. So all these blocks can be given safely. But remember, the vascularity, volume, and dose can predispose to last, more so because of the high cardiac output and local blood flow. So dilute your LA. If you're giving too much of volume, be careful that it can produce a compartment syndrome. Epinephrine can be used for facial plane blocks to decrease the absorption, and obviously, please do it under monitoring. So now this is the very recent article by a doyen of pediatric regional anesthesiologist, Longquist. Now he has actually challenged. Now this is just a view that he says that facial plane blocks in children are whether they are scientifically supported or not. So what he says, this is his viewpoint. He has reviewed the various literature, systemic analysis, RCTs, and he is in favor of using vector sheet blocks because it is predictable in spread and the plasma concentrations are acceptable. He has virtually negated the TAP block. He says that if you're doing it for herniatomies, ilioinguinal and iliohypogastric is a better choice. But TAP block may be better than providing no block at all in infraumbilical surgeries. But remember, sufficient dose and volume is required. And because of the lymphatics and tissue absorption, you can have very high plasma levels. But it is not better than caudal analgesia for infraumbilical surgery. Quadratus lumborum block, which is widely being used now. Again, the anterior block is less reliable, causes a patchy effect. As you move posteriorly, it has got a better effect. But for that, an expertise is required. And again, they have said that it is marginally better than caudal. And would you actually go in for less thing? But then this is his perspective, and this is food for future research. This is where the research is actually to be performed in pediatric regional anesthesia facial plane blocks. Now, what he has said is that transmuscular QLB, which is distinct from QLB 1 and 3, is better. If you have to use a quadratus lumborum block in children, better going for a transmuscular QLB because it provides dense somatic and vessel block, because there is a spillover of the drug to the paravertebral space and some spillover to the lumbar plexus, which can cause lower limb thickness. So it's a very good block for your laparoscopic surgeries, renal surgeries, and other surgeries in that area. So that can be tried. Again, this is food for further research. Erector spinae block, as in adults, it is very easy to learn and perform. There is no absorption phase, but there's an ultra fast high plasma level. So please be careful whenever you are administering erector spinae block in children, because you can easily end up with last, and the drug deposit there act as a depot effect. There's some amount of intraspinal spread also, because since the fascia and the tissues are thin, there's percolation of the drug, it spreads to the surrounding tissues, and the spread is really good. So that is why you require a slightly larger volume also, because there is loss from the intended space as well. So with that, I'll end my talk, and thank you. We'll take questions at the end. Thank you so much.
Thank you, Dr. Nishant. Now will be I will be introducing Dr. Anshu Gupta. She's a director professor in the Department of Anesthesia, Lady Hardinge Medical College, and she will be talking about local anesthesia and adjuvants used in pediatric patients.
Thank you, Dr. Maitree. Thank you ICA for giving me the opportunity, and thank you Jayashree ma'am and Baljit sir, and good evening everyone. So you have been listening to Dr. Maitree and Dr. Nishant. As madam said that spinal anesthesia wears off faster, but most of the blocks and other things takes longer time in children. So I'll be talking more about doses and drugs. There'll be some amount of repetition as well, but I think the repetition is good. At least for me, I think it's a difficult topic. And so let's go on with that. So I'll be talking about prolonging regional anesthesia along with overall drug and dose effect.
Dr. Anshu, kindly
So
make
full screen, sir.
Yeah.
Huh. So whenever we are planning this regional anesthesia for a child, we have to think about site and severity of the surgery, anticipate how much duration is required and what will be the intensity of pain, and hospitalization will be there or child will be discharged early. So if the child is to be discharged early, the drugs to be used are short-acting drugs like lidocaine and chloroprocaine. While for inpatient, most commonly used drugs are ropivacaine, levobupivacaine, and bupivacaine. So this is a slide showing distribution of body fluids. As we can see that in preterm neonate, total body fluid is around 80 to 85%, which decreases to 50% to 55% in adults. And intracellular fluid increases with age, while extracellular fluid decreases with age. And here we can see protein binding. With I think the drug names are not visible, but the trend is the same. This upper one is lignocaine. That protein binding is in neonate it is 25%, while in adult it is 55 to 65%. So similarly, distribution of volume at steady state is also more in neonate as compared to adult, and clearance is less in neonate. So the same is the trend with all the drugs, and this one is ropivacaine, where protein binding is same with neonate as well as in adults. So this is the table which was shown by Dr. Nishant also. It gives us mostly drugs for first First column shows the bolus dose with last is repeat injections, while intermediate column shows the continuous infusion. So for bolus doses, first we have to notice that we do not use higher concentration in children like 0.5% or this thing. So recommended concentration is 0.25% up to 2.25% for bupivacaine and 0.2% for ropivacaine. And similarly, this continuous infusion where concentrations are further lower, and bolus dose repeat injections also have lower concentrations. So for initial dose, around 0.25% is used, along with epinephrine 1 in 2 lakh. If child is less than 20 kg, 0.75 ml per kg is the dose, and over between 20 to 40 kg, 8 to 10 ml, and if child is more than 40 kg, the doses are same as for adults. And when we have to repeat these injections, the dose is 0.1 to 0.3 ml per kg every 6 to 12 hourly, and the concentration of solution is 0.1 to 5% or even 0.0625%. With ropivacaine also, concentration is 0.15 to 0.2%, but doses are the same. And as far as continuous infusion is concerned, we have divided the slots into child with less than 4 months, infant with less than 4 months, and 4 to 18 months. So less than 4 months, 0.2 ml per kg. 4 to 18 months, 0.25 ml per kg. This is 0.2 milligram per kg. ML is, because it is ML is 0.15 ml per kg. That is 0.125% solution hai, so ML will be different. So 0.2 milligram will come in 0.15 ml per kg. So for 4 to 18 months, it's 0.2 ml per kg, and for bigger children, it is 0.3 ml per kg. It's easier to remember like that. Solution is same, 0.1 to 5%, and if we make it further half, 0.06 to 5%, then that ml per kg doubles. So you can see in Miller also. So continuous infusions produce steady state concentration over 24-hour period. The drugs used are bupivacaine, levobupivacaine. And again, as I told you, 0.2 milligram per kg less than 4 months, 0.25 milligram per kg per hour more than 4 months, and more than adolescent ke liye 0.3 milligram per kg per hour for levo, and 0.4 milligram per kg per hour for ropivacaine. And bupivacaine is not preferred in pediatric age group because others have less toxicity. Levobupivacaine and ropivacaine are preferred. So these are the toxicity levels. So this epidural morphine, when we give suppose one bolus dose of epidural morphine, it reaches peak plasma concentration in 10 minutes. But that plasma concentration is not sufficient for providing analgesia. And that morphine which is in CSF and in plasma, both are eliminated at a similar rate. But concentration of morphine is more in CSF, so effect of morphine is because of its concentration in CSF. While shorter acting lipid soluble agents like fentanyl, sufentanil, they have shorter duration of action. So either we require several injections or continuous infusion. So their primary effect is via systemic absorption. So the difference is that because these fentanyl and sufentanil are acting via systemic absorption, the chances of respiratory depression are more with them. While morphine, there is usually the side effect and depression is progressive and delayed, and it is preceded by other side effects like pruritus, sedation, and bradypnea. So in a way, morphine is safer. And as Dr. Nishant said, this is the only adjuvant which is approved by FDA as of now. So another thing is whenever we give an epidural injection, there is a concept of Tmax and Cmax. Cmax is the maximum concentration reached and Tmax is the time to reach the maximum concentration. So when we use bupivacaine, the Cmax and Tmax are not affected as the age varies, and it is around 30 minutes for all age groups. While using levobupivacaine in less than 2 years of age, Cmax is more and Tmax is delayed. Tmax is 50 minutes versus 30 minutes in a more age group children or adults. And ropivacaine is altogether different. Here also Cmax is higher and Tmax is prolonged, but this prolongation is up to 2 hours. And another thing is that with the local anesthetics, as I showed, plasma protein binding is low in neonates and children, small children. So chances of systemic toxicity might be high. And moreover, that cardiac toxicity is not preceded by neurotoxicity. Both occur simultaneously. So it's not that we'll get one thing and that will warn us for another. And L-enantiomers have lower cardiotoxicity and they are preferred especially for infusions. Some advantages of ropivacaine are, one thing is it permits differential nerve block. That is why it is preferred for postoperative and operative analgesia also. And it has limited myotoxicity. And as I told, that Tmax reaches up to 2 hours. So it might reduce the maximum plasma concentration and systemic toxicity with ropivacaine. And plasma concentration of ropivacaine and its metabolite both are unaffected by the duration of infusion. So it is more predictable. Over a period, accumulation is less in this. So however, even with ropivacaine, epidural infusion should not be maintained for longer than 36 hours in infant less than 3 months of age. Now the question arises, first bolus dose we have given, especially in neonates. So how much to give in repeat injections? So we should decrease the dose to 1/3 for a repeat injection, and we should not repeat in less than 30 to 45 minutes. Another way is decreasing the dose to half and do not repeat before 60 to 90 minutes. And suppose we have to repeat further, then dose is further halved. Like it becomes 1/6 of the initial dose. So we have the habit of, not knowing the pediatric doses and just giving the doses, decreasing on the basis of adult doses. That is not right. We can see the doses are so low in pediatric age group. So this is the doses for plexus block, peripheral nerve blocks, and interfacial plane blocks. So for plexus block and interfacial plane blocks, around 0.5 ml per kg is the dose. And infusion rate is for plexus block 0.1 to 0.2 ml per kg per hour. While for interfacial plane block, we require higher volume. So the rate is 0.5 ml per kg per hour for a single catheter. And for peripheral nerve blocks, that is, if they are distal, then we require less doses, 0.05 to 0.2 ml. per kg. So the drugs concentration used are for plexus block, ropivacaine, it's same 0.1 to 0.2% for both. And for levobupivacaine, it's 0.125% to 0.25%, and for lidocaine, 0.25% to 0.5%. So these additives, they are used for prolonging the block. And in fact, in many cases, they eliminate the need for putting epidural at all. We can use additives in single shot only. So they can be added neuraxially or peripherally. So opioid adjuvants are usually used for neuraxial sites, not at peripheral sites. And more, as I already told, elimination half-life of additives is considerably increased in neonates and infants. So they have they act for a longer time, and they are to be avoided better in children less than 6 months of age. Epinephrine 1 in 2 lakh concentration can be used. It can be combined with local anesthetic, and it is usually co-administered. The advantage is that it itself prolongs the duration, especially in children less than 4 years. And another benefit is that it can help in detecting intravascular injection. But there is some fear, although it is not confirmed, of spinal ischemia. So some pediatric anesthetists use epinephrine in the dose of 1 and 4 lakh also. This decreases the abruption by 25%. So these are the doses of additives. Morphine recommended doses in doses different for intrathecal as compared to epidural. Intrathecal doses are less; they are 10 mics per kg, and for epidural it is 20 mics per kg, and we should not go beyond 50 mics per kg. For fentanyl, 1 to 1.5 mics per kg epidural dose. Supentanil is more potent, so 0.25 to 0.5. Clonidine and dexmed in the doses of 1 to 1.5 mics per kg, and ketamine is in milligram, that is 0.5 milligram per kg, not more than 1 milligram per kg. And S-enantiomer is better, and we have to remember that we have to use preservative-free drugs for neuraxial things. So clonidine is an alpha-2 agonist. It increases the duration of regional block and decreases the peak plasma concentration. Some sedation is caused by it. And as I told you that if you, all of us are doing it, surgery takes a little longer duration. Spinal will not last. Add clonidine, we'll get away with that. And we usually get away in most of the cases. So it decreases the need of catheter placement. And clearance is 1/3 in neonate, and instances of respiratory depression are reported. So again, avoid in less than 6 months of life. Dexmedetomidine is another alpha-2 agonist. It is still not recommended for use in neuraxial blockade, but it is used as an adjunct to prolonged peripheral nerve block. Neurotoxicity is a concern basically for using in neuraxial blockade, although few discrete studies are there regarding this. So this dose provide analgesia up to 8 hours. In fact, practically we have seen it more than that, but this is what is given in literature. And it is to be given in safe doses. Doses are very important, and again we have to, look for bradycardia and sedation. Ketamine is NMDA receptor antagonist, and it interacts with sodium channels as well. And co-administration in the doses of 0.25 to 0.5 milligram per kg has many hours of analgesia, and not obvious side effects, still not approved by US FDA. Other additives like corticosteroids, buprenorphine, neostigmine, tramadol, midazolam, all of them, they show side effects, and they are not approved to use in children. So there are paucity in pediatric studies regarding, especially with continuous infusion and all that. So for safe use, low concentration of local anesthetic should be tried or used. Then peripheral nerve catheters have been used for prolonging the blockade. So they are effective, they have less morbidity and allow early discharge of the patient. Again, low concentration of levobupivacaine or ropivacaine in the doses of 0.1 to 0.2 0.1 to 0.2% with 2 to 5 ml per hour, or on-demand injections of 2 to 5 ml. PCA, that is patient control analgesia, has also been used in pediatric patients. And children, even as less as children around 2 to 3 years of age, and that reduces the doses. And there was a study by Deflo et al. That they compared continuous administration of 0.1 ml per kg per hour versus PCA of 0.02 ml per kg per hour infusion with boluses of 0.1 ml per kg every 30 minutes. So of 0.02% and they found that PCA group had lower hourly consumption of drug and lower ropivacaine levels. So and that there was another study where continuous epidural infusion was compared with continuous SOAS compartmental block at 0.2 ml per kg per hour, and the plasma concentration with the compartmental block was lower as compared to epidural. And USG-guided intrafacial plain blocks are being popular nowadays, as we have discussed in last lectures also. But here again, they need more volume. So total dose is important, especially in neonates, underweight children, or children with organ dysfunction. So this is ASPIRE, that is alternating side programmed intermittent repeated bolus regimes. This say that if the you'd give 0.5 ml per kg with the catheter, but if the catheter, and repeat hourly. But if the catheter is bilateral, you repeat every 2 hours, and every 60 minutes you alternate the catheters. Like one side catheter, you give the dose, next hour you give another catheter, then again come back to the same catheter after 2 hours. So that decreases the toxicity. Thank you.
Thank you, Dr. Anshu, for such an elaborate discussion. Our next speaker is Dr. Nitin Hayaran, and he's a professor in our department at Lady Hardinge Medical College. He'll be speaking on the nightmares of local anesthetics in regional anesthesia. Dr. Nitin, please.
Slides are visible, ma'am?
Yes, they are visible.
Okay. Good evening, everybody. So, I will be discussing about the nightmares or the important complications that we usually, the pediatric renal anesthesiologists, face during the application of these blocks. So, till now, we have known that it is increasingly being used in pediatric anesthesia as it has significant advantages in managing pain, improving surgical outcomes, and as well as decrease in the opioid consumption. And with the advance of the technology, with the use of the ultrasound-guided renal anesthesia, it has made it safer and more precise for use in children. Therefore, now the blocks are increased. But thankfully, the nightmares that are the severe complications are rare, but they are critical. Especially, they have potential for long-term harm, like chronic pain, sensory deficits, functional impairment, affecting child's development and quality of life. These complications, they may rapidly escalate, especially the last or the high spinal block, to life-threatening scenarios like seizures, cardiac arrest, or respiratory failure. So these are the vulnerable population. They have unique physiological characteristics, as we have already discussed, and therefore they have susceptible to severe outcomes. They have a long-lasting impact, psychological impact, especially emotional distress for child and the family. And the medical legal implications are always there, especially when there is a complication. So I think we have already discussed the risk multipliers of these complications that are associated with these pediatric differences in anatomy as well as pharmacology. We know that the close proximity of the structures, the immature myelination, the higher uptake of the local anesthetic because of the high cardiac output, the narrow safety margins because of the volume to dose ratios, and the pharmacokinetics of the local anesthetic in neonates and infants, and that is why they are at high risk. And the high risk scenarios, which are the high risk scenarios in the renal anesthesia, which are there that leads to the increased incidence of complications, especially the neonates and the premature infants are at high risk of these complications. So the ma'am has discussed about the PRAN study, and there is one more study, it is ADAR study, that says that the children less than 6 months of age are at 4 times higher in risk of developing any of the complication, along with the coexisting conditions like coagulopathies and neuromuscular disorder. Emergency procedures have higher incidence of the complication, and high dose multi-level blocks also have an increase in chances of these complications. When we compare the neurological and peripheral blocks, the literature reports that there are 6 times higher incidence of the complication with neurological as compared to the peripheral block. And the most important, especially whatever we say, whatever we do, the resources are always limited. The availability of USG, the availability of good needles, the availability of the injection pressure monitor or the patient monitors. And with suboptimal training, they may lead to the high risk scenarios in pediatric regional anesthesia. So, ma'am has already discussed about the performance of regional anesthesia under general anesthesia. So this is the dictum now. Most of the blocks are being performed under GA, and though the complications are very less, but there may be some unanticipated motor blockade during a continuous post-operative period that will let us rethink what has happened during the application of the block, because patient is not aware, cannot complain at the time of the injection. So let's start with the first most dreaded nightmare that anesthetics can have in the OT is the local anesthetic systemic toxicity, or LAS. So I have taken, this is the usual scenario, an infant that is being taken for a below umbilical surgery likening one hernia repair with no medical history, full term, no known allergies, normal physical examination, normal laboratory tests. You induce with GA sevoflurane with IV fentanyl. You insert an LMA, uneventful. You give a higher dose of caudal block, 1.5 ml per kg of bupivacaine, 0.25%. And within 5 minutes, we can see there is an GTCS, bradycardia, hypotension, and cardiac arrest is followed shortly. So what has happened? That is basically a local anesthetic systemic toxicity because of the rapid systemic absorption of the drug that affects on the cardiovascular, the central nervous system, as well as the cardiovascular system, myocardiality. So management basically is comprised of the cardiopulmonary resuscitation as per the guidelines. Apart from that, we have the intralipid rescue with 20% intralipid. The dosing regimens are now changed. They are now recommending a higher dosage with 1.5 ml per kg as a loading bolus, followed by 0.25 milligram per kg per minute for the next 15 to 20 minutes, and total of around 12 ml per kg within 30 minutes. The guidelines also mentions the use of the ECMO, is especially if the intralipid has not worked within the first 6 minutes. So ECMO has found as a life-saving adjunct for the patient suffering with local anesthetic systemic toxicity. Apart from that, there are now the real-time pharmacokinetic monitoring tools that can help us in detect the initiation of the LAS. Before that, I want to reiterate about the preventive modalities. I think as those has already been discussed by ma'am. You know that there are a lot of false negative results, especially when the patient is under GA. So what is recommended is to inject LA solution very slowly in small liquids with intermittent aspiration and observation of ECG tracing. Any modification of T wave or heart rate within 30 to 90 seconds after injection of a test dose, it is interpreted as accidental IV injection until disproven. So that is important for you to know. And apart from that, the doses has been mentioned by all the previous speakers. You always follow the ESRA and the ASRA guidelines for the maximum dose of for pediatric renal anesthesia. Currently, what monitoring tools we can apply? So currently, now we have processed EEG monitors. So this electroencephalogram can detect early neurotoxicity by identifying CNS excitation before patterns before patient throw up overt seizure. So that is one thing. Hemodynamic monitoring, I think we all are doing. They will be helpful in detecting arrhythmias like prolonged PR or QRS interval or ventricular dysrhythmias. They monitor bradycardia or hypotension as early signs of cardiovascular toxicity. This gas chromatography or mass spectrometry is still in the research phase that can measure the concentration of local anesthetic accurately. So now these are the emerging monitoring approaches that are being developed, and they may be available in market, I think, soon. So like biosensors for local anesthetic detection, so like they are the electrochemical or fluorescence-based biosensors that detect early concentration in the blood in real time. So this is still in the experimental. We have now a prototype, but still is very in the experimental phase. So then you will be able to identify the exact concentration of the local anesthetic real time. What we have, glucometers, point of care are being developed, wearable technologies are being developed, and now the people are working on continuous monitoring of with the vital parameters with AI integration. So they are integrating the trends in ECG, EEG, and hemodynamics that predicts an impending toxicity based on subtle changes. So these are the advancement that are being going on in the field of this last. Another nightmare is that in the on the second day of the surgery, now surgeon is saying now patient is not able to move both the limbs after a successful intraoperative lumbar epidural. So the epidural hematoma again is a very difficult and a silent threat, and it usually presents after 24 to 48 hours. So usually the risk factors are undiagnosed thrombocytopenia or coagulation defects, or there is a multiple efforts, or there is a difficult catheter placement, especially in small children. So the signs and symptoms usually are delayed onset paralysis. So patient have regained its muscle. Again, it leads to again patient develops paralysis, bladder dysfunction. So diagnosis is basically done by MRs or CT for rapid diagnosis. But now this is again in an experimental phase, and IRS electrodes are being can be kept at the level of spine for detecting the spinal cord perfusion. So they are again this is in the experimental mode. So the treatment remains immediate neurosurgical referral, and there is a controversy regarding the steroid use, early use of steroids. So steroid, though it decreases the edema, but it may mask the symptoms of the compression, delaying the definitive treatment, that is neurosurgical treatment, evacuation. But there is still there is a controversy regarding steroid use. Again, the second usually surgeon comes after 2 to 3 days and saying that now this patient, you gave this sciatic block or a popliteal block. Now patient is having this persistent paresthesia, and patient is crying, and now what to do? So basically, this is a very complex presentation. Patient will present like persistent paresthesia or sometimes late onset neuropathy also. So after 4 days or 7 days, patient may present with paresthesias. So this usually occurs when you give a local anesthetic in a closed compartment alongside the nerve. So it leads to the drug-induced ischemia or prolonged compression of the nerve, or you go for an intraneural injection. And like already have been mentioned, a lot of the additives are not recommended. So they have a direct neurotoxic effect on the nerve. So that may also lead to this paresthesia. So high resolution nerve ultrasound and electrodiagnostic studies will help in the diagnosis as well as assessment of these patients. Again, the same like hematoma patient now, this complaints with the fever as well as the some neurological deficit, and you diagnosis of an epidural abscess has been made. So now pathogen trends are changing. So it was like Staphylococcus epidermidis, aureus. Now because of the normal flora of the pediatric ward is changing. So a lot of multi-drug resistant organism epidural abscess has also been found in the recent literature. Early empirical antibiotics tailored to the the antibiogram of this area should be done, and use of advanced aseptic techniques like the chlorhexidine dressings, or now some catheter technology has also been trying to be developed for its antimicrobial capacity. But now, still now we are using antimicrobial dressing for that. So impact of delayed diagnosis on, there is a long-term morbidity. So when we say about the prevention, so though they are rare, but may occur with single shot, they are very rare. They occur when may occur with catheters in patients with bacteremia. The risk of more severe infection is very rare, around 0.03%. So we need to strictly adhere the aseptic technique in maintenance of equipment sterility, especially the accidental disconnection. It has to be discarded. The study says that lumbar thoracic epidural are safe as compared to caudal. Idea is to daily inspect the site. Any suspicion of redness, remove the catheter immediately. So patient may present with fever, headache, signs of meningeal irritation, urgent scan, and if there are neurological signs, you do go for surgical spinal decompression. If there are no neurological impairment, go for antibiotics and catheter removal. Another problem is that you have put a block and you know that it is very important for you in the next 24 hours, and there is a catheter misplacement, and especially in infant, it may go intravascular, intrathecal, and it may go unilateral. So now the patient is complaining of heaviness in the one limb, or there is a patchy block. So it is very difficult for it's to manage. So important thing is to have you can go for an AI-based ultrasound guidance, especially when the block is being put by a novice clinician. So it usually allows to identify the exact location or the nerves that are there. I have came across a infusion pump with integrated pressure monitoring. If the catheter migrates, it will tell that now the pressure is has changed. So that is one thing that is coming up that can be utilized in the for the catheter management. Another problem is that sometimes there is a ankle fracture or a tibial bone fixation, and the surgeon is saying, please don't put in any block, no epidural, no caudal, as this patient may develop a compartment syndrome. So they are mostly very common with fractures of the limb, crush injuries, and vascular compromise. And they say that pain he will tell whether compartment is developing or not. And that is why they contraindicate the management of pain. But the National Pediatric Epidural Audit of UK, ESRA guidelines, they say even with the help of appropriate pain management, even with the help of continuous epidural analgesia, does not include the early diagnosis of compartment syndrome. Though they have advocated avoid the continuous block in high-risk cases, use single injection techniques with short-acting agent to reduce the prolonged masking of pain, with combining it with multimodal analgesia. Or if you want to have, you have to use it with the lowest effective dose. Carefully monitor other signs of acute compartment syndrome like swelling, tight compartment, and change in perfusion. So earlier what we did, saw the change in perfusion with the help of pulse ox. That is a very crude method. Nowadays we have the NIRS probes that are there for the pediatric as well as infants, and they can be helpful in monitoring the tissue oxygenation for monitoring the ischemia. Now we can also go for a compartment pressure measurement. So development of small catheters with integrated pressure sensors for real-time compartment monitoring. So the critical threshold has been described as more than 30 mm of Hg or within 20 mm of Hg of the diastolic flow. If it reaches this value, it warrants an intervention or opening of the facial compartment. Ongoing trials are also undergoing to evaluate the role of biomarkers of ischemia like lactate, CKMB as early predictors of ACS, still in the experimental phase. So basically, for any of the complication, there is a simple algorithm. You go for prevention, basically screening of the patient, optimize dosing, try for an ultrasound-guided placement, especially for precise placement, recognize the critical signs, go for, especially with the help of real-time monitoring, immediate treatment, and escalation to specialized care. So here we say stop, breathe, and act for the crisis. Stop, think, and act for the management of the. So to conclude, pediatric patients require specialized care and vigilance. Complications can be reduced with adherence to guidelines. Early recognition and treatment are key to manage adverse events. Pediatrics challenges amplify risk. And call to action is prioritize research and training to minimize harm. Thank you.
Thank you, Dr. Nitin. That brings us to the end of this webinar. Now I hand over the mic to Dr. Kumar. Are there any questions in the chat box?
There was one already.
It has
but
been answered. Huh?
Dr. Nishant has already answered that.
Ma'am, I think we should take the pre-test questions that we had taken up. I'll
Yeah.
just share the screen. So, ma'am, you can answer, or Dr. Anshu can answer the question.
You have it, you answer. You have the thing, no? You show it.
I'll show it, ma'am. Yeah.
At birth, the diameter ends at S3 or S4. Are they? Someone is there so that they can put in the chat box, or we have to answer? It is for us or for the students?
Ma'am, we have to discuss. So we have to answer.
Okay. So at birth, the diameter ends at S3 or S4 vertebral level. The answer is number 1.
Number 1. The maximum dose of plain levobupivacaine as local anesthetic is. So the answer is C, 3 mg per kg. Which of the following is the most common complication associated with pediatric regional anesthesia? Dr. Nitin?
Last local anesthetic. As per the
So
plan.
you have to be very careful about the volumes and the dose that you are administering. So long-term complication of pediatric regional anesthesia?
Again, chronic pain due to nerve injuries. That will be the long-term complication.
So dose of 0.5% bupivacaine heavy for subarachnoid block in a neonate is 0.5 mg per kg. So it is basically less than 5 kg is 0.5, 5 to 15 is 0.4, and more than 15 kg is 0.3, and above that is more than 35 to 40 kg is 0.2 mg per kg. So that is the dose which is there for bupivacaine heavy. So with that, I think the questions have been answered. So over to you, sir, Dr. Baljeet. If you can.
Dr. Kumar, you have something to say?
Sir, I would like to thank ICA and all the speakers and Maitree ma'am for such a excellent webinar. And in fact, the questions were also very good and pertinent to the topics discussed. And pediatric regional anesthesia and in fact, neonatal regional anesthesia is also something which has been very rightly taken up by ICA for discussion. And thank you so much, sir.
Okay, friends, thank you so much, all the speakers. Wonderful job that you have done. Each topic had its own novelty, and they were delivered very nicely in a manner that could very easily, I mean, anybody would understand very easily. I'm sure the youngsters would have loved every word of all that has been said by all the 4 speakers. And as is the customary, I would like to thank on behalf of Indian College of Anesthesiologists, all the speakers and the moderator, Dr. Maitree Pandey particularly. We look forward to having you again on ICA platform for some other presentation for some other topics. And before I conclude, I would also like to thank Shreyasi on behalf of Clarinet for putting up the whole program for all of us. So thank you till we meet again. Stay happy, stay healthy, and God bless you all. We meet next Wednesday again. Good night.
Good night.
Thank you so much.
Thank you.
Good night. Thank you so much.
Good night, ma'am.
Right, ma'am.
Thank you, sir. Thank you so much,
Thank
everyone,
you.
for giving us the opportunity to host the session. Thank you. Good night to all
Good
of you.
night. Good night.
Bye.
And
Good
thank you
night.
very
Good night,
much.
Thank you,
Thank
ma'am.
you.
Good night.
Thank you.
Thank you, ma'am.
you.
Bye bye.
Thank you,
Thank you,
ma'am.
ma'am.
Thank you,
Maitree.
sir.
Thank you so much. Thanks a lot. by Nitin, Nishant,
Thank you, ma'am.
Anju, Anshu. Bye, Maitree.
Thank you, ma'am, and thank you, sir. Thank you, Dr. Baljeet.
Thank you.
Thank you so much.